Welcome to the Board of Directors meeting for June 25th, 2014. If you'd all join me in the pledge.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, if you take the roll for us, please.
Yes. Director Stewart.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Epen.
Present.
And Director Wallace is away.
Yes. Thank you very much. I'd like, for just a minute, to change the order of our agenda tonight. I want to move to oral communications first. And I have a statement that I'd like to read. First, before we open the floor to comments from the public, I'd like to make a few remarks about the recently released report from the Alameda County Civil Grand Jury. I know I can speak for my colleagues when I say that the board appreciates the grand jury's efforts. First, I want to assure the district's residents that the care and services provided by Washington Hospital were never part of the grand jury inquiry, and the report acknowledges that for more than 50 years the hospital has provided state-of-the-art medical care to the community. When we learned about this initial inquiry by the Alameda County Civil Grand Jury, this board and the executive leadership of the hospital worked diligently to respond to all aspects of the grand jury's inquiry. In addition to thousands of pages of documents carefully organized to aid the grand jury in its inquiry, both the hospital's CEO, Nancy Farber, and I, as president of the board, sat before the grand jury and responded to any and all questions they had. We were thoughtful, thorough, and transparent in our responses and in the supporting documents we provided. With regard to the conflict of interest allegations, we note that the grand jury concluded that none occurred. This board and the CEO followed the requirements of the law. All of our actions were free of conflict and fully transparent. It is time for us to move on. Additionally, while donation information is usually confidential, I have been given permission by Ms. Farber to disclose that she has completed an initial personal pledge of personal monies of $50,000 to support the hospital's foundation's capital campaign. And she is in the process of completing a second personal $50,000 pledge. She has also given other personal donations that I am unaware of the amounts. This is a piece of information that I do not believe the grand jury was aware of. In terms of the report's criticisms about transparency, I think it's time that we as a board consider this in detail. The fact is that our district is unique. We have both responsibility to the public and responsibility to the operations of our hospital's performance that is in a very competitive landscape. Not many public agencies or public agency boards do that in a similar way that we do. These two things at times create tremendous challenges for us. However, we can always do things better. So I would like to take this time to review our practices, to look at other practices, and to examine what, if any, changes should be made to improve transparency. Accordingly, I would like to ask that the grand jury report be placed on a future agenda as soon as reasonably possible, so that the board can discuss that. In the meantime, I would also like to ask Nancy Farber and her staff to consider the report with the goal of making recommendations to this board on how we might improve our transparency. I would like to see not only the grand jury report addressed, but other areas and ideas on how we might be more transparent. Nancy?
Thank you. We will schedule this for a future meeting as soon as reasonably possible, and it's my understanding we have 90 days to prepare a formal response to the grand jury, but the goal is to get back to the grand jury as soon as possible. As you know, we have a lot on our plate right now, but I understand that this matter is of pressing importance, and we will do everything we can to provide the board with the information that it needs to take action.
Thank you. Thank you. We'll proceed with that at our earliest convenience. In other communications, are there any other oral communications this evening? Seeing none, we can then move to our education session, the main purpose of our meeting this evening, which will be consideration for the budget estimate for fiscal year 2014-2015.
Thank you. It's my pleasure tonight to begin the presentation, but also here and speaking extensively tonight are two individuals from our finance division, Chris Henry and Daniel Nardoni. I think everybody here is quite familiar with Chris Henry. He's our Chief Financial Officer, but in case you've forgotten his background, I'll share that with you. He has a Bachelor of Science degree from Cal State East Bay in business administration with an accounting emphasis. He worked in public accounting for 4 years, after which he was certified as a public accountant. He joined our hospital as Director of Accounting in May of 2000. In December 2003, he was promoted to Controller. Since October 2006, he has served as our district's Chief Financial Officer. In October of 2010, he took on the additional responsibility of an Associate Administrator. He's a member of the California Society of Public Accountants, California Hospital Association, Healthcare Financial Management Association, the American Institute of CPAs, and he also serves on the California Hospital Association's CFO Advisory Committee and is active in the District Hospital Leadership Forum. A little bit about Dan Nardoni before I start. Mr. Nardoni graduated from Cal State University, East Bay. It says Hayward, and I'm sure that's where the degree came from, but I'm going to be politically correct. It's Cal State East Bay these days. He received a Bachelor of Science degree in Business Administration with an emphasis in accounting in 1991. He spent 3 years in public accounting with Arthur Anderson, working in their healthcare practice, followed by 5 years with Sutter Health as a senior accountant. In 2000, Dan joined Washington Hospital as a senior accountant. After 5 years in this position, he was promoted to budget manager. In 2009, he took on the additional responsibilities as the Director of Budgeting and Ancillary Financial Services, and in 2011, he was made Senior Director. He recently completed coursework at the University of California, Irvine, receiving his Master of Business Administration in Healthcare Administration. So those are the introductions for the two gentlemen that will be carrying the bulk of this presentation. I just want to touch on a few things in my letter of transmittal. On June 11th, the Board of Directors met in open session and received a presentation from me, from Don Pipkin, and from Chris Henry, talking about the radical changes in the healthcare economic environment. And I don't want to go over those again. But if people are curious about what's precipitated all of this, I would refer them to that meeting. It's on tape. If you want a DVD, we can provide that for you. It's on the television station 78 now. This budget estimate for the district projects an expenditure authority for $482,664,000. Overall, this represents a 10.2% decrease in projected expenditures from last year to this year's budget, this year being fiscal year 14-15. It is consistent with the known and anticipated reductions in reimbursement and patient care activity that flow not only from the Affordable Care Act, but also from the very significant changes in Medicare reimbursement that we discussed on the 11th. Now, labor is the district hospital's largest component of expense. The budget includes a decrease in labor costs, largely a result of reductions that occurred over the course of this fiscal year, the one that we will be leaving on June 30. And it is related to attrition and staffing for lower volumes. Proposed capital expenditure requests are 21.8% lower than the previous budget. Charity care, as distinct from bad debt, is anticipated to be $19,100,000, which is consistent with our experience this year. Other things I wanted to touch on is last year when we presented the budget to the Board of Directors, we talked about uncertainty as the prevailing characteristic of the time. This year, the most apt description would not be uncertainty. Rather, it would be best depicted as massive, disruptive change held in check only somewhat by pending national elections. What will happen after the November elections is as of yet unknown and could have a huge impact on our hospital, like every other hospital in the country. We have to wait and see what happens. The growth in the high deductible, high copay plans over the course of the past year has created very serious problems, not only for the district hospital, but for the patients and their families. So it's a financial burden that we all seem to share. Like last year, concerns about safety net hospitals are a very real issue. The fate of St. Rose still hangs in the balance. Both San Leandro Memorial Hospital and Alameda Hospital District have been absorbed by Alameda County Medical Center and very well may not be operated as general acute care hospitals in the future. Palm Drive has closed. Doctors Hospital of Pinole, formerly Brookside Hospital District, is teetering on the brink. I think that community is doing everything they can to save that hospital, but the economic equations aren't there. Valley Care has executed an agreement to explore their future with Stanford University Medical Center, looking for a partner to shore up their financial position. And the Daughters of Charity have put 4 of their San Francisco Bay Area hospitals on the market. We've been looking a little bit ahead at what's going to be happening with premiums in the coming year. In 10 states where filings have been completed for 2015, the largest health insurers, the Blues, and several others, are bringing forth increases in premiums between 8.5% and 22.8%, with more and more purchasers of health plans being individuals, not employment groups. They have almost no leverage. The playing field is not level. This year, we prepared to implement ICD-10. We spent roughly $3 million to get ready. Those preparations are not lost. What saved us is their decision to cancel ICD-10 this year occurred, I think, literally a week or two before we were going to begin spending significant money on training. So that $3 million has been spent, but I think it won't lose its value. They are promising that there will be no cancellation this October. They've already done it 3 times. It's something that is very expensive and disruptive, and so we'll see how that goes, but that is one of the unknowns. In this fiscal year's plans and priorities, we had indicated that we were preparing for a Joint Commission survey. The Joint Commission has not arrived yet, so it looks like this is something that will be carried over into the next fiscal year. It's not likely that the Joint Commission would come the week of the 4th of July. On our plans and priorities, medication safety and infection control are paramount. We're looking at operating room safety initiatives. We are looking at filling out our UCSF affiliation and building programs with them. Things that we're interested in doing include palliative care, cancer genetics. The special care nursery is already in place and functioning very well. I heard just before this meeting started that we have 7 babies in place, and another baby being brought back to the area from Lucille Salter Packard Children's Hospital, being transferred over here because the parents live here. So it is functioning very well. The pediatric hospitalists are in the process of also being changed over to UC. Cardiovascular surgery is an area of emphasis that we want to pursue with UC, as well as a perinatal diagnostic clinic for high-risk mothers. And we're also looking at the possibility of participating in an ACO that UCSF is beginning to design. With our EPIC electronic health record, we are looking at a shared services collaborative, which is something that the board had recommended we do. We will also this year request the board to give us permission to install Beaker, which is a clinical lab system, and we will be doing the 2014 upgrade to EPIC. ICD-10, as I mentioned before, is a toss-up. Who knows? We also are going to be pursuing renewal of our magnet designation for nursing. In terms of construction, we have the parking facility, which is also our heliport, the Morris Hyman Pavilion, and we need to do some renovation in the blood bank in the existing hospital, and those are the 3 pieces of construction we'll be looking to accomplish. We have a patient satisfaction initiative underway with Washington Hospital and also the Medical Foundation. We will be bringing Rona here in the fall to begin teaching us about lean practices. We have a VHA cost reduction program underway. We're looking at a GYN and oncology program. We're participating in a regional transfer program where patients are flown here by helicopter from all parts of Northern California. We are in the process of negotiating our SEIU contract, and this year we'll also be updating our facility master plan. We'll be looking also at the development of a more robust case management program here. So that's what we're hoping to accomplish in the next fiscal year, and those are the main elements of the institutional agenda. So with that, I'd like to turn this over to Chris Henry.
Good evening. Before I get started, I want to say some thank yous. This budget this year, as Nancy mentioned, was created in an environment of massive and disruptive change. It was a challenging budget this year and required a lot of work from a lot of people. This is the culmination of work from the entire management staff of Washington Hospital. Some of them you see sitting here tonight. I see a lot of the nurse managers here. They were very active in this budget and really appreciate their work. I see Vera, Mike Engel, all of the folks in this room really had integral part in producing this budget. In particular, I really want to thank Kimberly Hartz, Ed Fayen, Bryant Welch, Stephanie Williams, Tina Nunes. All 6 of these folks spent many early mornings and late evenings with Dan and I combing through our budgets and making sure that they were adequate and not overdone. Really shooting to get to the numbers we needed. I want to thank Dan Nardoni. Dan, as you all know, is kind of the ringmaster of the numbers. Dan takes the input from all these folks and puts them into something that we can all comprehend, and it's a lot of work and a lot of hours, and Dan, really appreciate your work on that. I want to thank Colleen Dorr, who is my assistant and the ringmaster of me and keeping me going where I need to go and reviewing all this work and making sure that the numbers tick and tie and is accurate and producing copies after copies for folks to review. So Colleen, thank you for your hours of work. And of course, Nancy Farber. Nancy couldn't get through this without your leadership and your guidance and your insight and your knowledge. This budget could not be produced without that, and I can't thank you enough for your support and your help in this. So with that being said, let's jump in. As Nancy mentioned, we spent a good portion of the meeting 2 weeks ago talking about the environment that we're working in, and I'm going to spend just a short time reminding you of some of the things we talked about. I think Don Pipkin's analogy hit the nail on the head when he referred to the Affordable Care Act as building the airplane while taxiing down the runway, although I think the only change I might make to that is it's already taken off and it's left the runway and we're still building it. We talked about the delays of things. It's been kind of a hurry up and slow down. The ACA, the president has delayed a number of the provisions of the ACA here recently out past the election. The delay in the requirements for private insurance plans, delays for the large employer penalty and the small business health options, the ACA employer mandate for medium-sized employers. All these things have been pushed out beyond the election, and we really have yet to see what they're going to do after. We expect there will be more changes, more delays, but that is yet to come. Recently, Congress again delayed the fix to the sustainable growth rate. This is the 17th time in 11 years that this issue has been kicked down the road. This most recent delay is expected to cost CMS $15 million. And the real big issue here is that a permanent fix, it's been projected by the Congressional Budget Office to cost $175 million by 2023, or billion, I said million, billion with a B, the big number. So it's really a difficult situation because a lot of the financing for the ACA was dependent on ratcheting down on the sustainable growth rate. So we have yet to see what's going on there. Also, Nancy mentioned the ICD-10 and 2 midnight rules were delayed until at least October 2015. The most recent estimate I saw is that this is the third time that ICD-10 has been delayed. This delay, it's been estimated, will cost the industry $6.6 billion. Now, we were fortunate enough to be at a place in our development of compliance for ICD-10 where we'll be able to keep what we've got, but a lot of organizations will lose some significant money on this, and it's unfortunate. We talked a little bit about the gap in our Medicare payment to what it costs for us to provide care to Medicare beneficiaries. We didn't talk Wednesday night about the Medi-Cal issue, and that's additive to that. So we did discuss that the shortfall in Medicare reimbursement was about $86.3 billion, but if you add to that the shortfall in Medi-Cal of $45 billion, we end up with a number that's well over $131 million of unreimbursed cost that then gets passed on through the chain of private insurance, ultimately to ratepayers, employers and individuals buying insurance in the form of a hidden tax in higher premiums. Last week we talked about some of the challenges we're having with declining reimbursement. The ACA issues here, value-based purchasing, readmissions, coding capture, disproportionate share, are the most significant items. It's certainly not a comprehensive list of the reductions we've taken. But the Medicare component of this alone over the last 5 years, or over the last 4 years and projected through 2015, we're expecting to be a cumulative over $33 billion. We don't think this is the end. We think we're going to hear about more after the election. they still have a significant problem with their inflow-outflow equation to solve. And if they fix the sustainable growth rate, they're going to have to find funding from other sources. So more yet to come on that. So you combine all the environment that we're living in with reduced reimbursement, and then we add on the issues of unfunded mandates. In California, we have a particularly unique unfunded mandate in the form of California seismic standards for hospitals. And essentially what this does is all hospitals in California have to meet the standards set by the state by 2030, or we cannot use our inpatient facilities for inpatient care. So you have to be seismically compliant or people can't spend the night. Since 2003, more than 30 Bay Area hospital construction projects, as you see here, worth more than $100 million or more have been started, completed, or are planned to begin, like our construction project about to start. The projected spend on those projects is estimated to be at over $20 billion in total, and you see the cost that a lot of these healthcare organizations are incurring to comply with the seismic standards. You add on top of this federal unfunded mandates, such as the requirement to use an electronic health record. For Washington Hospital, that cost was $86 million. And the requirement to comply with ICD-10, that's a very expensive proposition for us, about $7 million. And you start to see the strain that these unfunded mandates are putting, particularly on California hospitals, but other hospitals nationwide. Bring this home a little bit to us. I want to explain a little bit about depreciation for those folks who aren't familiar with accounting. So when we at Washington Hospital buy an asset, say we build a building, we pay the contractors to build the building in a year or two, money out the door. But what depreciation does is it recognizes the cost of that building over its lifespan in the period that a particular portion of that cost is used. So for a building, it's depreciated over a period of anywhere between 25 and 40 years, depending on its use and its construction. And that cost of that building is then recognized in increments over that period of time, up to 40 years or 25 years or whatever the useful life of that building is estimated to be. So when you add in the significant capital expenditures that, for instance, Washington Hospital is making to comply with these unfunded mandates, and we start recognizing depreciation in our income statement, it adds up to some big dollars. So for us here at Washington Hospital, cost of construction that we've estimated at over $500 million by the time we're done with the new building, and including the other buildings and the power plant that we've built to comply with seismic, that's added a depreciation load onto our income statement of a bit over $21 million. Likewise, the cost of Epic and ICD-10 are going to add on to that depreciation load to the tune of, by the time we're done building this building, we're estimating about $33 million in additional depreciation resulting from complying with unfunded mandates. So, it's a difficult situation. It's one that we can get by. Let's talk a little bit about the electronic health record and meaningful use. So, one of the federal mandates that came out in the ACA is that hospitals must be using and providing meaningful use of an electronic health record by the year 2015. And they've provided some incentives for us to do that in the form of a payment that we can qualify for if we meet certain stages of meaningful use reporting. And this is reporting of statistics and other things. For Washington Hospital, the meaningful use estimated funds, and I also want to explain, this is based on the federal fiscal year, which is different from our fiscal year here at Washington Hospital. Our fiscal year starts July 1 and ends June 30th. The federal fiscal year starts October 1st and ends September 30th. So these numbers are based on the federal fiscal year. We have available to us in federal fiscal year 14, $2.3 million, in 15, $1.3 million, and you see these numbers are scaling down as we get further and further along. And in federal fiscal year 2016, about $800,000. Now, what you have to factor in there is the cost of complying with meaningful use, and you see these numbers down here. $776,000 in 14, $498,000 in 15, and about $1 million we're projecting in 16. When you look at those 16 numbers, it kind of begs the question as to why would you try to comply with meaningful use if you're spending $1 million to get $800,000? And of course, keep in mind that we spent $86 million on this system to begin with. What happens in 2015 is hospitals that are not demonstrating meaningful use of an electronic health record start to get penalized. It starts with 1% starting January 2015. It starts with 1%. That's about $1 million to Washington Hospital. It increases in 1% increments for 5 years to a maximum of 5%. And for Washington Hospital, not complying with these regulations would cost us $5 million a year off of our bottom line. So they've kind of trapped us into doing this. It's not an option. We have to do it, or there's serious fiscal penalties for that. So again, we're creating this budget in a difficult situation, but not one we can't work out of. And enough of all the gloominess. Let's talk about the good stuff now. We've really still, at Washington Hospital, through all of this, kept our commitment to our mission and our patient-first ethic. And so during fiscal 14, even though we're dealing with all this change, we're still making really good accomplishments. We were awarded or recognized as a baby-friendly hospital by the World Health Organization this year and the United Nations Children's Fund. We were recertified as a primary stroke center by the Joint Commission. We received American Heart Association and American Stroke Association's Get With the Guidelines Gold Plus Quality Achievement and Target Stroke Honor Roll. That is really a significant achievement for the folks that work in the neuro program in Stephanie. We again were acknowledged for our quality with awards for Quest for Zero in both OB and the ER. And we were rated excellent by Consumer Reports for our scheduled surgeries. We were also rated the fourth best hospital in the Bay Area by the U.S. News and World Report, and we're very proud of that. Now, generally this list would be longer, and what's missing here is awards that we generally receive from Health Grades. Health Grades requires a rather hefty fee for us to publicize those awards. We decided that in a year where we were really reevaluating our operation, that we decided this was not a prudent expenditure this year. So we did not pay the fee, and we cannot publicize those awards this year. So again, all of this reflects our commitment to our mission statement. And the budget is really the financial embodiment of our mission statement, and it provides the ability for us to go out and do what we do for our community and for our patients. And I just like to remind folks that it is not just something that happens in patient care. It's embodied in this budget and permeates throughout the organization. So let's take a quick run through what the 2014 budget provides for, and we'll get into details of many of these things as we move along tonight. The 2015 budget provides for total revenue of $182.6 million. It provides for funding of our depreciation expense of about $33 million. It provides for funding of contributions to our retirement plan of $17.7 million. It allows us to provide debt service on our revenue and general obligation bonds. It sets net income targets at $1.9 million for operating income and total net income of $15.6 million. And that includes our property tax revenue of $9.9 million, which is restricted to the debt service on our general obligation bonds. It provides for funding of $14.5 million to our development corporation, and that includes Washington Township Medical Foundation, and that is a really important investment for us. The Medical Foundation provides about, actually is responsible for about 25% of our admissions. It includes about, I believe the number is about 25% of our surgeries and about 25% of our gross revenue. So significant contributions to the hospital and significant access to care for the residents of our district provided by the Medical Foundation. It also provides for new capital spending requests of $16.4 million. We'll get into the details of this, but this is a number that we really paid a lot of attention to, given the fact that we are experiencing some challenges. We started with requests of over $22 million and really got down to the essentials of this. And like I said, we'll get into the details of that. Quick run through the income statement. So the budget provides, again, for net patient service revenue of about $264.7 million. Other operating income of a little over $4 million, for total operating revenue of $468.9 million. We expect operating expenses, and we'll get into the details of all these, of about $467 million in 2015. Giving us income from operations a little over $1.9 million. We add in our non-operating income, which is really the income we have to work with at the end of the day, of about $5.7 million. It again provides for general obligation bond tax revenue of $9.9 million, which we cannot use for our operations, to give us a total bottom line expected at $15.6 million. And all these numbers start with the volumes, and I'm going to step aside for a few minutes, and I'm going to invite Dan Nardoni up to the podium to walk us through the volume assumptions for next year.
Good evening. I want to start by thanking Nancy and Chris for giving me the opportunity to present the volumes for the 2015 budget. Preparing the budget this year was difficult for all of the many reasons that Chris and Nancy have mentioned. However, the collaborative spirit of the executive management team prevailed, and that's the reason we were able to present this here to you tonight. And I also wanted to thank all the management staff that participated in this process. Okay, so let's get into the numbers. The 2015 budget provides for admissions of 11,877. As you can see, this is about a 4% increase over 2014. This increase really reflects a full year of operation of the special care nursery. Patient days of 57,307 and average daily census of 157 are up about 0.5% in the budget. This also is a reflection of the full year of operation of the special care nursery. Outpatient observation days of 2,580 are coming down to about 22.2%. This decrease is expected as we prepare to open our ED observation unit. Historically, these patients have been treated and scattered around all of our medical surgical floors. And by centralizing them into this unit, we believe that this will create better care for those patients. Our average length of stay is coming down to 4.83 in the budget. This is expected as we work on operational improvement projects throughout the year. deliveries of 1,720 are expected to remain consistent with 2014 levels, and surgical cases of 4,169 are also maintaining 2014 levels of activity. The cath lab volume of 4,410 is expected to hold at 2014 levels as well. Our emergency room visits are budgeted at 50,908. As you see, a slight decrease. This decrease represents the trend that we've been seeing over the last 6 months of operations there. And our non-emergency outpatient visits are coming in at 91,260, which is also reflective of the 2014 level of activity. Moving into our performance indicators, total paid FTEs are budgeted at 1,318.8, which is about 9% lower than the fiscal year 14 activity, or what we've averaged. In 2014, you remember we had the implementation of Epic at the beginning of the year and the resources necessary to accomplish that. Since that implementation, we've continued to reduce staffing levels to take into account the clinical volumes that we realized and the attrition that's happened over the year. What lies ahead for us here are reductions for voluntary retirements. However, we don't know at this time how many other paid positions will have to be dealt with as the year unfolds. It is our Chief Executive Officer's strong feeling that a reduction in force is the absolute last option, and that this feeling is consistent with prior practice in this. Okay, so let's move into some of our trends. Admissions there at 11,877, as you can see, is a slight uptick. Inpatient days as well at 57,307. There's deliveries at 1,720. Total surgeries there at 4,169, consistent with 2014. And there's the emergency room visits following that trend that we talked about at 50,908. And the outpatient non-emergency outpatient visits of 91,260 at that same level of activity as 2014. And then there's our admissions by payer. As you can see, Medicare and Medi-Cal here are pretty consistent with 2014 levels, but you do see upticks for HMO and PPO payers. And this again is related to the special care nursery activity that we're expecting in this next coming year. And with that, I'll turn it back over to Chris to run through the financials.
You know, I just wanted to make a quick note on one of the slides Dan just showed, which was the non-ER outpatient visits. You saw the steep downturn that occurred in this current year, and it's very apparent to us that that is the effect of the introduction of price sensitivity into the market, and so we're going to be watching that because that's not going to go away. Yeah, and really the big driver there is the clinical lab. So folks are shopping price. One of the projects we're going to talk about in a little while is we're going to be taking a close look at our charge master this year. So let's move into the numbers. So gross patient revenue expected to drop about 1.1%. Again, this is a reflection of the volume changes Dan just went through. Our contractual allowances following closely to that, and for folks who aren't familiar with what our contractual allowances are, you've heard us say before that nobody pays gross charges here, and nobody does. What this number represents is the amounts that we write off of a bill due to particular contractual agreements with particular payers, to Medicare, to HMO PPOs, to Medi-Cal, and also it reflects the discounts we provide to private pay payers. So our contractual allowances are following closely, but not dropping quite as much on a percentage basis as the gross revenue. That's a reflection of an offset to, we do expect significant, about $12 million in increased net revenue from our new relationship with the special care nursery, but that's being offset by a full year of the reductions that were imposed on us by Medicare this year. I talked a little bit earlier about the federal fiscal year. So in the timing of all this, there are several months in Washington Hospital's fiscal year where those reductions weren't in place early last year. So really those gains are being offset by a full year of the reductions from Medicare and other payers. So we end up with net patient service revenue for Washington Hospital in 2015 estimated to drop about 1.6% to $464,740,000. Our provision for charity care and doubtful accounts we expect to be on par as a percentage of gross revenue as last year, coming in at about $64.5 million, giving us total net patient service revenue expected for fiscal 2015 at $400,225,000. Other operating revenue expected to drop about 25%. Large part of that is the reduction in meaningful use funds that I just described a little bit earlier. We are also no longer have a lease for the Level 2 nursery under the new relationship, so that lease income won't be going away, but will be ongoing as an impact to the bottom line for Washington Hospital. So again, other operating revenue dropping to about $4.2 million. And now let's take a run through the operating expenses. Salaries and benefits both dropping about 9% during the new year. And again, that's a reflection of primarily seeing a full year of the reductions that we were able to accomplish through attrition in fiscal 14. Those occurred throughout the year as volumes reduced and folks, left the organization for various reasons. We're going to see a full year's impact of those reductions in 2015. Professional fees going up about 1.4%. A minute ago, I mentioned the Charge Master project that we're going to be taking on. We realize that our Charge Master really is the product of 30 or so years of a system that is no longer in play, and it's time to take a look at that and get our Charge Master in line with the new world. It is our intent as we go through this project to make sure that residents of the district will receive some discounts as we move through that project. That is going to be a multi-phase project that you'll be hearing about throughout the year. It's got to be done carefully, but we are resolved to do it. It's time to get our Charge Master consistent with the new world. Supplies, see a reduction in supplies there of about 3.6%. That's largely driven by the volume changes that Dan discussed. And we have some operational improvement projects going on during the year. Purchase services, see a big increase there, and that's a reflection of some of the consultants we're going to bring in to help us with some operational improvements. We're going to be looking at all areas of the hospital and really cranking down to make sure that we're operating efficiently. We're going to be bringing in Virginia Mason style lean. We're going to be doing some work with case management and some other areas of the hospital. So these monies will bear fruit during the year and in coming years. Utilities, it's about a 7.4% increase in utilities. It's time for us to do a new negotiation for a gas contract, and we expected to have an increase there. Also, it's tough to tell what's going to happen with the price of water this year in California. I live in Livermore, and my bill's going up, and I'm sure our bills are going to go up here, but how far we don't know. So we've provided some increases there. Also, some increases related to garbage collection and electricity provided there. Insurance, about a decrease of $165,000. I mentioned those Quest for Zero recognitions that we got. Those quality indicators are recognized by Beta Healthcare Group, our insurance carrier, and they were generous enough to give us some discounts on our insurance as a result of the hard work that was done in OB and in the emergency room. So thank you very much. Let's see, marketing and advertising. We'll see about a $44,000 increase there. We intend to start publicizing our relationship with UCSF and the various projects we have going on with them. It's time to let people know the good work we're doing with UCSF. Software licenses and maintenance, about a $216,000 uptick there. That is a reflection of a full year of licenses and maintenance for Epic. Last year, while we were in the process of installing, those things were covered by warranty, and now we have the maintenance contracts to cover that. Okay, so other expenses. About a $735,000 decrease in other expenses. The biggest driver there is decreases in equipment rentals. We intend to replace some beds this year. That's driving some of that. And the volume in general reduces the amount we have to spend to rent specialty equipment and that sort of thing. So we're seeing a decrease there. Other also includes our building and equipment leases. Miscellaneous things like postage, fees, and licenses are expected to be about $322,000. The majority of that going to the state of California in the form of OSHPD fees and building permits and that sort of thing. So the state of California gets into our pocket pretty healthily there. So that's other expenses. I mentioned our provision for charity and doubtful accounts. We expect that to stay consistent with this year at about 3.2% of gross revenue. This number could change. We're still not quite sure at what the expanded proliferation of high deductible health plans, what impact that will have on bad debt. The initial read was that everybody's going to be insured. You're going to get paid better, but our fear is that as employers start to provide health insurance plans and ask their employees to go buy their insurance on the health exchange rather than to provide the very good benefits that they have now, that in fact this number may go up. So we're going to be watching this as things roll out. We don't expect any large changes there as a result of this, of either the health exchange or the Medi-Cal expansion. These folks, if they can't afford to pay for their care now, they're certainly not going to be able to pay $5,000 to $8,000 deductible plus a 30% copay. I mean, it's just, it's not feasible. So we'll be watching this number as that develops. Depreciation we discussed a little earlier in our interest expense for the year, dropping just a little bit as we begin our construction and some of that begins to be capitalized. So that's a run through the operating expenses. Distribution of expenses, no big changes here. This is actually quite reflective of us in past years and of other hospitals in the industry, with labor costs making up fully 50% of our expense profile, followed by pro fees and purchase services and bad debt and charity. Supplies making up about 11% of the mix, depreciation and interest about 9%, and some of the many sundry other costs making about 3% of our expense profile. We'll take a run through our non-operating income. The biggest mover here is our investment income, dropping about 25%. That is a reflection of the move that the board made this year to fund the pension plan in a significant amount, reducing the amounts that we have in reserve in our funded depreciation. That interest earnings doesn't go away. It shifts with those funds into the pension plan for its benefit. So Again, about a 25% decrease expected in our investment income. As always, we do not budget for realized or unrealized gains on our investments. It is absolutely impossible, particularly in this volatile environment that we've been in, to determine what the bond markets are going to do. So we'll wait and see on those numbers. And then, of course, you see down below, no bond issuance costs this year. We do not expect to go out for the second half of our general obligation bond issues until we're well underway with construction of the Morris Hyman Critical Care Pavilion. And of course, our general obligation bond property tax revenue coming in about $9.9 million to cover the debt service on our general obligation bonds this year. So total non-operating income expected for 2015 to be about $13.7 million. So now let's run through the capital. Capital requests this year, as I said, we really looked at what we really have to do. It became pretty evident early on this year that as our volumes started to drop, money was going to be tight. I think last year this board approved requests of about $22 million. When things started to get tight, we stopped spending on capital and really held that spending to about $10 million in 2014. Again, we took a very thoughtful approach to capital requests this year, and here's what's included. Civic Center Drive upgrades. This is the next phase of work that needs to be done on Civic Center Drive to make the area safe for folks crossing Civic Center Drive at that crosswalk. This is a project that we've all worked together on for years, frankly, and finally coming to fruition. So this is the last bit of work we need to do on Civic Center Drive to complete those plans to make this safer for both hospital employees and the general public that use that crosswalk to get to and from BART and other parts of the city. So we'll be doing that this year. The building maintenance system upgrades of about $218,000. This is a project to replace the control panels in the existing hospital that are old and analog. These control panels regulate the flow of hot and cold water that in turn regulate the heating and cooling system in the hospital. They're vital pieces of equipment. They are old, they're antiquated, they've been prone to having issues here recently, and it's time to replace them. And then again, for facilities projects, a number of projects, less than 200, really only one. What that $33,000 represents is some money that needs to be spent throughout the campus to make sure that the police and fire can communicate with each other throughout the campus in the situation of an emergency. This year when we went through an emergency preparedness drill, it became apparent that there were some black spots here in the campus. So we need to get that rectified so those folks can communicate during an emergency. IT projects totaling about $14 million will be brought before you during the year. Epic 2014 being the main one. This is an upgrade to the Epic system that is required at this point. When we installed Epic, the version that was available at the time was a 2010 version. So now we are 2 versions down the road. We need to get this thing upgraded. It includes 28 enhancements that improve efficiency of use, and most importantly, additional safety of documentation as well as patient care. So this is an upgrade we need to move forward with. We've also included a request for funding of the replacement of our clinical lab system. Our current clinical lab system is more than 10 years old. It's no longer in support, and it doesn't talk to Epic. And so it's time to replace that system, so we'll be coming forward with a request for that. We have a number of non-Epic software upgrades totaling about $650,000. A lot of these are to some of the McKesson systems that are left, the financial systems, the material management systems. We are numerous versions out of behind, out of sync, and it's time to upgrade those systems to make sure we don't start having problems with them. And then again, a number of projects under $200,000 that we'll be bringing forward to you for consideration, including an upgrade to the hospital's wireless system. Our wireless system now is old, and a lot of the new equipment coming in operates on new protocols and can't talk to the system in certain areas of the hospital, so we need to get those things upgraded. Also included in that is a replacement to the WALT patient education system. Again, that's another very, very old system, and it's time to bring it up to speed. Some of the equipment that we'll be bringing forward, like a microscope, about $261,000. We have provided about $234,000 in the budget for updating computers. You know, our computers in this day and age are almost disposable. They last 2, maybe 3 years, so we've provided some money to provide replacements as those things go. We're going to be bringing forward an endoscopic video camera and some other equipment under $250,000. So again, as a summary, we'll be bringing forward to the board for consideration about $15.4 million in total projects and equipment of about $1 million. That's a pretty lean budget for us. I think that's the leanest capital budget I can remember. So again, down to the gotta-haves and things we really need to do. Also this year, just to remind the board, spending on previously approved projects will be coming forward of about $59.1 million. Of course, the lion's share of those in our new building projects on the Morris Hyman Critical Care Pavilion and the parking garage, both of those being funded by the generosity of the district residents and their approval of general obligation bond funding for those. And ICD-10, we think. We'll see as we get down the road if that's going to get pushed out yet again. So that's a pretty daunting change, moving from roughly 12,000 codes to 69,000 codes. So we'll see if the federal government's ready and if they think we're ready on October 1st. So that's the capital budget or capital and operating budget we'd like you to consider tonight. And if there are any questions, I'm happy to answer them.
Anxious to entertain questions.
Yeah, Chris, one of the concerns I have is we are still operating in an area of uncertainty, although we're fairly certain things are not going to be that great in the years ahead. What mechanisms do we have in place to adjust the budget as we proceed on through the year? What do we have that's forward-looking to see, are we on track? Are we on our flight plan?
Yeah. Yeah.
Are we getting off track, and how we can, in the middle of the budget year, make adjustments? What things should we be looking at with respect to reimbursements or volumes? What specifics do we have to give us a forward-looking approach?
Yeah, well, I'll tell you, the first thing and foremost thing that can change this is what the federal government does. And I think we're going to really have to watch closely after the election. A lot of the things that were painful were pushed out beyond the election. We expect, once the election occurs, to see a lot of activity in Washington, and we're going to have to watch that closely. We're going to have to analyze the news that comes out of Washington, and we may well be bringing you a revised budget shortly after the election. Insofar as outside of Washington, we have built into our budgets standards that automatically flex down with volumes in particularly a number of the clinical areas. We have also fixed departments such as finance, part of my area. And we stay acutely attuned to what's going on with volume this year. While all the clinical departments were flexing down, we were pushing people out to take vacation to make sure that those folks are participating in that. So those are the budget is built that way to automatically move, even though it's not necessarily reflected in the fixed budgets that you see month by month. The budgets automatically move and are tied to volume.
Yeah.
I'd like to add to that for the board's consideration. The reason why November is important is not just what's happening with the national election. There is a measure that's going to come before the voters that did not go through the legislature. It's the initiative process. And it is disguised as a safety bill. And I forget what its proper name is, but it has to do with drug and alcohol testing of physicians. What's embedded in that is the repeal of MICRA. Last time we went through something like that in the state of California in 76 and 77, we had a doctor's strike. If MICRA's repealed and the insurance premiums skyrocket, we have massive disruption in our ability to provide medical services to our patients. And this hasn't happened now for 40, 50 years, but here we go. It's a definite risk. So what happens with that ballot could force us to come to the board in November and completely redo our budget. I think the decisions around physician sequestration for physician fees, what they're looking at, if they were to follow the process that they've put forward, is a 25% decrease in what they're going to pay physicians for Medicare. I would imagine that would be the moment in time where a lot of physicians just decide they're not going to participate in Medicare. That could also present a huge disruption in how we provide care. There are a lot of very big, bad things out there that we have no control over. And we have to sit and wait. So come November, there is going to be some recalibrating and some discussions, and it will be brought here to the public board meeting so that our community knows what's going on and what impact we think it's having. But we're going to have to follow this quarter by quarter. I think we have the appropriate performance indicators in place. What we don't have is any control over the environment. It's like being in a free fall. It's scary as can be. And when I stop and I think about this budget that was presented, if we were an ordinary business, like running a hardware store or a restaurant, who in their right mind would take on a capital building program and the installation of a computer system in a time when they're making less money than they ever made before? No businessman in their right mind would do that. And to some extent, people have to acknowledge we're a business. We are, but no margin, no mission. Nobody in their right mind running a store out in the community would take on those kinds of projects. We have no choice. They've been mandated. The penalties for not doing them are extreme. So here we are. We're expected to function as a business, have a bottom line, and we are compelled to spend $86 million to install Epic, and the ongoing fees of operating that system you have been exposed to tonight, and a construction program. The seismic laws have driven hospitals to construction, and what you saw tonight were a list of hospitals that built for the 2015, or what have they moved to 2018? Ed, I can't remember. Anyway, that's a first compliance level. There's another one we have to meet in 2030. There's a second one. So it's not just one wave of construction. It's going to be successive waves of construction. And if you don't meet their standards for seismic compliance, you're not allowed to keep patients in your hospital overnight. And when we talk to our lobbyists in Washington, D.C., they say the mood in Washington is not particularly sympathetic to hospitals, and they think it would be fine if hospitals closed, that we have too many beds. And I look at the population of baby boomers coming of age, and I'm wondering, what are they thinking? So these are very, very strange times that are going to test every last one of us.
I think our most important characteristic of our own institution here is our ability to remain agile. Being an independent district, having an independent board of directors tightly coupled to the people give us that agility to respond to these changing situations. It's going to be a real challenge.
Yes, it is.
When I think of our airplane in flight analogy again, I see, the things that have been thrown at us by the feds and the state as flak, and we're going to have to fly through a lot of flak. When I think about the proposed proposition that will be on the November ballot to make changes to the MICRA law, I look at that as a surface-to-air missile, which will have tremendous danger to the general provision of medical care within our community and for all of our population.
Absolutely.
So I think you're right in that we have a number of events that are going to be happening within the next 6 months, which are going to help determine the fate of this institution as well as all the patients that we serve. So I think we need to be
I
very
agree.
mindful of that and be able to respond. Fortunately, in the past, we've been able to make those adjustments and keep things on track.
Everybody has been complimented by Chris for their role in all of this, and no one has thanked Chris. And I'd like to do that. This has not been easy. There's been a lot of lost sleep and anxiety and long nights and weekends putting this together. This was one of the most difficult processes I've been through because there is so much change and the results of that change are so unpredictable.
Right.
A lot of moving parts.
Yeah.
Mhm.
A lot of moving parts.
I just wanted to mention also, I was encouraged that we're looking at Virginia Mason lean program. I think that also will position us for the future. And I think we need to congratulate those that have looked into that for us and looking to do that in the future. I think it'll make us stronger in the end.
I hope so. That's my hope and my belief.
Yeah. Any other comments from other members of the board? Chris, thank you very much. And Dan, thank you very much. You both have been very, very gracious in thanking all those that helped you, but I'm positive that when the rubber met the road, you guys were the ones on the line. And we, as a board, appreciate all that you've done. You've done a very, very significant job there. Thank you for your work. And we'll all hope and pray that we're online here in another couple of months. At any rate, thank you again. We're now ready to take action on that budget that has just been presented to us. Dr. Epen?
Mr. President, I move for the adoption of resolution number 1146, which is a budget estimate for fiscal year 2014-2015. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operation to promote the charitable and community services mission of the district.
Do Do we have a second?
Second.
We got 2 seconds, that's good. Any discussion that needs to be made at this point on this issue? We'll call a vote on that. Catherine?
Yes. Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Danielson,
Aye.
Director Epen.
Aye.
Thank you.
That's unanimous. We're ready to go.
Thank you very much.
Thank you. Thank you for all those that have worked so hard on this issue. Appreciate everything that's been done. There being no further business here this evening, we are now adjourned. Thank you all for attending.